Bismillahirrahmanirrahim. Assalamu alaikum, respected viewers and respected students. I am Dr. Muhammad Ramadan Ansari. I'm Assistant Professor of Pediatrics, and this lecture is about acute respiratory infection in WHO classification perspective. Acute respiratory infections are divided into upper respiratory tract infections and lower respiratory tract infections. Acute upper respiratory and lower respiratory tract infections, the cutoff line is vocal cords. Any infection above the vocal cord will be called acute upper respiratory infection, and any infection involving the area or airway below the vocal cords will be labeled as acute lower respiratory infections. So upper respiratory tract infections include sinusitis, rhinitis, rhinosinusitis, otitis media, pharyngitis, flu, tonsillitis, epiglottitis, whereas acute lower respiratory infections include acute laryngotracheobronchitis, also called ALTB, or CRU, can be bacterial laryngitis, bacterial tracheitis, bronchiolitis, and pneumonia are the other forms of acute lower respiratory infections. Because presenting complaints of all these respiratory infections are almost same, so it is difficult to differentiate one from the other. That's why this clinical classification is given by WHO for all healthcare worker. Even a simple medical technician can apply this classification, and an expert child specialist, a senior child specialist can apply the same clinical classification and can manage the children very well. This classification and management protocol, this is not just a simple document, it's a miracle which has saved lives of millions of people. The presenting complaints are usually cough, shortness of breath, fever, poor feeding, vomiting, bluish discoloration of tongue or extremities are general danger signs like loss of consciousness, seizures, lethargy. On general physical examination, after taking history of symptoms, now you need to elicit certain signs. First of all, respiratory rate is to be taken. Make a count during 1 minute when the child is calm. For somebody to be defined tachypnic, or tachypnea is defined in less than 2 months, more than 60 or more than 60 breaths per minute. For 2 to 11 months, 50 or more than 50 breaths per minute will be defined tachypnea. And for children 1 to 5 years of age, 40 or more than 40 breaths per minute will be defined tachypnea. Lower chest wall indrawing is another very important clinical sign which will differentiate between pneumonia and severe pneumonia. When the lower chest wall goes in when the child breathes in, it is called lower chest wall indrawing. This is a pictorial depiction how the lower chest wall goes in when child breathes in. In addition to respiratory rate and lower chest wall indrawing, look for signs of respiratory distress, whether the child is grunting, is there nasal flaring, is there a wheeze, is there a stridor, is there cyanosis, is child has head nodding, is their JVP is raised, and is there concomitant anemia or not. Nasal flaring: when child breathes in, the sides of the nostrils flares outwards. This phenomena is called nasal flaring. Look for apex beat, whether displaced, trachea shifted from the midline or not. In case of collapse, apex beat and trachea will be shifted towards the same side of collapse. In case of effusion or pneumothorax, the trachea and apex beat will be shifted in the opposite direction. Then percussion is done to confirm the presence of collapse, consolidation, or effusion, or pneumothorax. In case of pleural effusion, it will be stony dull. In case of pneumothorax, it will be hyperresonant. And auscultation is done to check for the coarse crackles or bronchial breath sounds, which confirms the diagnosis of pneumonia. Now let's classify the severity of pneumonia on the basis of the history, that is symptoms, and signs which you have elicited. If you have only history of cough and cold, flu, runny nose, vomiting, and the child is in not any kind of respiratory distress, child doesn't have tachypnea, so we will say there's no sign of pneumonia or severe or very severe pneumonia. This is no pneumonia, rather it is cough or cold. This child should be given home care. He should be given soothing therapy for throat and relieving the cough with safe remedy. He should be given honey, warm water with honey can be given, soup can be given, broth. Advise the mother when to return. If the condition worsens, the mother need to come back to hospital. Follow up in 5 days if not improving. If coughing for more than 30 days, then chronic cough for tuberculosis, for pertussis, post-pertussis bronchiectasis have to be checked. And other causes of chronic cough like cystic fibrosis are to be looked into. Starting from pneumonia, starting from below upwards, if child has fast breathing, which we have already defined, our child has definite crackles on auscultation. This is defined, this is classified as pneumonia. Even a child with pneumonia can be given home care. Give appropriate antibiotic, oral antibiotic, penicillins, ampicillin, amoxicillin, and soothe the throat and relieve cough with a safe remedy. Safe remedy is away from the medicines which are given as bronchodilators or mucolytics or as antitussive. These are not safe remedies. Safe remedies are home treatments like ginger kawa, like soup, like broth, honey with warm water, like that kind of. Advise the mother when to return and follow up in 2 days. If child has pneumonia, follow up in 2 days. If in addition to fast breathing or auscultation or crackles on auscultations, if child has chest indrawing, this is severe pneumonia. Any child with severe pneumonia has signs of respiratory distress, and this child should be admitted to hospital. Antibiotic IV given, recommended antibiotic. The recommended antibiotic can be decided by your ward, by your department. Airways to be managed. Child may need clearing of the airway by normal saline nasal drop or by steam inhalation or by normal saline nebulizations, or sometimes bronchodilator might be our mucolytic agents, because beta 2 agonists also act as mucolytic agents, so sometimes mucolytic agent may also be needed. And treat high fever if present. This is very important line. Treat only high fever if present. If there is low grade fever, don't be worried, don't be over concentrated on the management of low grade fever. Treat high grade only if present. If child in addition to chest indrawing also has central cyanosis, severe respiratory distress, that is there is head nodding, not able to drink anything, then this is very severe pneumonia. Then admit this child to hospital, give recommended antibiotic, give oxygen, manage the airway and treat high fever if present. Now let us define the pneumonia. What is pneumonia away from WHO guidelines? Pneumonia is defined as inflammation of lung parenchyma distal to the terminal bronchioles, respiratory bronchioles, alveolar ducts. So involvement distal to the terminal bronchioles. What comes distal to the terminal bronchioles? Respiratory bronchioles, alveolar ducts, alveolar sacs, alveoli, and alveoli, and is associated with consolidation of the alveolar spaces. Pneumonia etiology. Organisms of pneumonia are different at different ages. In newborn, E. coli is the most common organism, followed by group B streptococci. then GBS, or GBS, and then Staph aureus, then Klebsiella, then Pseudomonas. In infancy, pneumococcus, and in infancy and older children, pneumococcus is the most common organism. And H. influenzae type B, the incidence has dramatically fallen since after the introduction of H. influenzae vaccine in the EPI schedule. Mycoplasma should be considered in all school-going children or contact of school-going children because it is usually acquired in age group 5 to 15 years. And mycoplasma can also involve adults as well, but school-going children are the highest risk group for acquiring atypical pneumonias caused by mycoplasma. Let's have a look on chest X-ray findings. This is a normal chest X-ray. Oblique ribs, central heart, no cardiomegaly, there is no reticulonodular shadow on the chest X-ray, on both lung fields are clear, both CP angles are acute. This is a chest X-ray of a lobar pneumonia of the right lower zone. There is consolidation of the right lower lobe which is causing a homogeneous opacity in the right lower zone of the right lung field. Lobar pneumonia is caused by pneumococcus usually. This is an example of staphylococcal pneumonia. Typical features include pneumatoceles on the right side of your picture and an abscess with air fluid level on the left side of the illustration. When this abscess ruptures into a bronchus, then it leaves behind a pneumatocele. Thank you very much.